the duration of the talk is 4 minutes, as you all know already. So I request you to kindly stick on to the time. The first talk will be by Dr. Pooja on orbital lymphoma, a case report.
A very good morning all, respected chairperson. Today I'll be presenting a case on orbital lymphoma. Myself Dr. Pooja, coming from Karnataka AIOC2023 Institute of Medical Sciences.
Can you load her presentation?
It's coming. It's not changing. Orbital lymphoma is one of the most common orbital tumors. It's a B-cell non-Hodgkin's lymphoma, and in most cases arises from the mucosa-associated lymphoid tissues. Contributes 2% of all lymphomas, 5 to 15% of all extranodal lymphomas, 50% of orbital malignancies, primary in adults. So the purpose of this study is to report a case of orbital lymphoma which was presented at a rural medical college. A 62-year-old male presented to us with severe proptosis with involvement of lids and adnexal region, lacrimal gland, cornea, conjunctiva with the Tenon's capsule. So on examination, there was a firm palpable mass in the fornicial conjunctiva as well as the lids, and a salmon pink colored mass was seen in the conjunctiva bulbar area involving the cornea as well as the subtenons. We went ahead and performed MRI, which showed iso to hypointense lesion extending from orbital apex up to the anterior orbit and encasement of the optic nerve and ocular muscles. So bits of tissues were taken from conjunctiva, palpable part of lacrimal gland, cornea, and was sent for histopathology. So on histopathology, it showed lymphoid cells arranged in sheets with prominent nucleoli. Further IHC was suggested and the patient was referred for the same to Kidwa Institute of Oncology at Bangalore. So patient underwent radiotherapy with significant improvement, mainly for cosmetic purpose, which showed reduction in proptosis. So no complications was observed at subsequent follow-ups post radiotherapy. The patient is being followed up for last 2 years. So you can, in the first photograph, you can notice the comparison between the pre and post radiotherapy with good systematic cosmetic appearance. No specific guidelines exist, but surgery combined with radiotherapy, chemotherapy has been seen in many cases. The difficulty of complete resection with preservation of function in the orbit may explain high relapse rate. Timely intervention in this case, supported by the histopathological diagnosis and radiotherapy, has improved patient's cosmesis in this case. We would like to thank Department of Pathology at AIOC2023 and Department of Radiotherapy and Pathology at Kidwa Institute of Oncology for timely diagnosis and helping us out in this case. On immunohistochemistry, it revealed low-grade indolent type of non-Hodgkin's lymphoma of extramarginal zone lymphoma. Yeah, these are my references. Thank you.
Thank you, doctor. It was a nice case. The change which radiotherapy has brought about is very phenomenal.
Yeah.
Did you mention about the visual acuity of the patient initially? Sorry, I missed the presentation.
Patient had no PL.
Did you mention that?
I know.
Yeah, okay, fine. So actually the challenge is in diagnosing orbital lymphomas in the early stage, I think. So
Yeah,
at this
yeah,
stage, it
yeah.
is, we all think it will definitely be a
This
malignancy.
was during COVID time, so he
Yeah.
presented to us
Very late.
at a very later stage.
Okay, thank you very much.
Yeah, thank you so much. Thank
So
you.
next we will have Dr. Rachna Shivaram. She'll be talking to us on role of automated perimetry in correlation with CT scan.
Good morning. I'm Dr. Brinda. I'm here to present a case of evolving pseudofoster Kennedy syndrome. Case history. Case history. A 49-year-old male, non-case of diabetes and hypertension, presented with complaints of sudden onset unilateral defective vision in the right eye since 2 weeks. Initially, it started as a Initially, it started as difficulty in seeing the lower half of the field of vision, which gradually progressed to involve the whole view. There was no history of trauma, diplopia, eye pain, pain on eye movements, no history of pain on combing hair or touching forehead. It was not associated with flashes of flutters. There was no associated with headache or projectile vomiting. On general and systemic examinations were normal. Moving on to ophthalmic examination, vision in the right eye was 2 by 60 with pinhole improving to 4 by 60. The anterior segment examination was normal except for early cortical cataract changes in the lens. The pupil was around 3 mm round, showing sluggish reaction to direct and consensual reflex. The fundus examination, the media was clear. The disc was hyperemic with blurred margins. Splinter hemorrhages were seen in and around the disc, which was more in the inferior aspect. The right eye optic disc showed a temporal disc pallor. The venules appear tortuous and dilated with a normal foveal reflex. Left eye, the vision was 6 by 18. The anterior segment was normal except for early cortical cataract changes. The pupil was around 3 mm round, showing sluggish reaction to direct and concentric reflexes. Fundus examination seemed the media was clear, hyperemic disc with blurred margins. Hemorrhages were seen in and around the disc, but there was no disc pallor. There was dilated tortuous venules with a normal foveal reflex. On management, the OCT macula and optic nerve head were taken. OCT macula was normal. Optic nerve head showed confirmed the disc edema. MRI brain was taken, which showed non-specific changes with no mass or tumor. Patient was started on a course of intravenous methylprednisolone followed by oral prednisolone. On follow-up, the vision in the right eye was 4 by 60. The left eye vision improved from 6 by 18 to 6 by 12. On fundus examination, the blurred margins and hemorrhages persisted in both eye fundus, but pallor ensued in the right optic disc. Discussion. The Foster-Kennedy syndrome is characterized by vision loss due to compressive optic atrophy in one eye and papilledema in the contralateral eye, brought about by an increased intracranial pressure. Pseudo-Foster-Kennedy syndrome is typically a bilateral but consecutive sequential optic neuropathy. Pseudo-Foster-Kennedy syndrome, it occurs as consequence of anterior ischemic optic neuropathy, in which active disease in the one eye is associated with contralateral optic atrophy in the other eye in the absence of intracranial mass. Conclusion. Pseudo-Foster-Kennedy syndrome is a rare entity and should always be kept in mind when the patient presents with features of AION with contralateral optic atrophy. An early course of systemic steroid should be considered in this patient as it can improve the visual outcome. These are my references. Thank you.
Thank you. What was the field of the left eye?
It was left eye alterneural field effect was seen.
Did you mention that?
No.
Yeah, that was the one which could tell you the diagnosis, right? So, good. Thank you.
Thanks.
Good morning, one and all. My topic is recurring cyst. So, craniopharyngioma are epithelial tumor arising along the path of craniopharyngeal duct. Incidence is 1.9 per 10 lakh. We reported 2 cases of cystic craniopharyngioma presented with different chief complaints and belonging to different age groups. We had performed comprehensive ophthalmic evaluation of 2 patients, which included detailed history, general physical examination, and ocular examination, including visual acuity, color vision, anterior segment examination, and disc evaluation. We had done investigations including routine hemogram, pituitary hormone assessment, HVF, OCT RNFL, ganglion cell analysis, and MRI brain. Also, we had done cross-referral to neurosurgeon and endocrinologist and regular visual function monitoring. So coming to case description, the first case was a 19-year-old male presented with complaints of painless, gradually progressed diminution of vision in right eye since 6 months, associated with onset of dull aching type of headache lasting for about half an hour. Also, he noticed increased appetite, weight gain, and fatigue. And the second case was a 4-year-old female child presented with complaints of gradually progressed outward deviation of left eye since past 1 year, associated with tiredness and sleeplessness, and she had normal birth history and postnatal and developmental milestones. So this was the first case. On examination, we noticed generalized loss of secondary sexual characters. Here we can note he didn't develop facial hairs and axillary hair. His BMI was 25.22 kg per meter square, and the other one was the second case. On ocular examination, First case, right eye BCVA was 3 by 60, color vision 1 by 17, and HBCT was central. Extraocular movements both eye full and free. Pupil grade 3 RAPD noted, and left eye vision and color vision was within normal limit. Optitis, partial optic atrophy not in both eyes, right eye more than left. And the second case, right eye BCVA 618, color vision 11 by 17, HBCT was 15-degree exotopia, and extraocular movements full and free in both eyes. Left eye vision was hand movement. We couldn't assess the color vision, and grade 3 RAPD not in left eye. Choky pallor of the disc was seen, left more than right. So this is the first case. We can see the partial optic atrophy more in right eye. And on visual field examination, left eye was showing inferior temporal quadrantopia, and right eye diffusely depressed fields. And on endocrinology evaluation, we notice significant decrease in the pituitary hormones. So diagnosis, partial optic atrophy, right more than left, with bitemporal depressed fields and endocrine dysfunction, suggesting cellular or supracellular lesion. So we had taken MRI brain. It was showing cystic intracellular mass with supracellular extension, compressing the optic chiasma. It was suggesting cystic craniopharyngioma. The second case MRI was also showing the same cystic intracellular mass. On OCT RNFL, it was showing diffuse thinning of all quadrants. Ganglion cell analysis was also showing diffuse thinning in all quadrants. And endocrinology evaluation was showing borderline low TSH. So both patients underwent transnasal transsphenodal drainage of the mass, but recurrence happened after a few months. So pterional craniotomy and drainage of the craniopharyngioma with placement of Ommaya reservoir done. Endocrinology consultation done, and start on hormone replacement therapy. Histopathology revealed adamantinomatous craniopharyngioma, and both patients underwent definitive radiotherapy later. So we'll see the follow-up. The first case we can see he developed the facial hairs and also axillary hair. So this is the red arrow shows the area where they placed the Ommaya reservoir. And the visual field pre and post surgery. Left eye we can see the quadrantopia was completely disappeared. Right eye was not showing much improvement. We can see after surgery the cyst was completely shrunken, and the time point also after surgery the size is reduced dramatically, and his vision in right eye improved to 636. Second case also the time point we can see the size is reduced dramatically after the surgery. So both patients continued hormone replacement therapy and visual function monitoring monthly. So in conclusion, craniopharyngioma may present with variety of manifestation in bimodal age distribution, and it has a significant surgical challenge due to adherence to the vital neurovascular structure. So early diagnosis, multimodal management, and regular monitoring for signs of recurrence is crucial. These are my references. Thank you.
Thank you, doctor. It was a nice presentation. Thank you very much.
Thank you, sir.
Next, we'll have Dr. Rohini Hari.
I'm Dr. Rohini Hari, junior resident from Sri Ramchandra Medical College, Chennai. I'll be presenting a case of Tolosa-Hunt syndrome mimicking retrobulbar neuritis. Tolosa-Hunt syndrome is an idiopathic sterile inflammation of cavernous sinus with episodic orbital pain associated with paralysis of one or more of third, fourth, and sixth cranial nerve, which usually resolves spontaneously but can relapse and remit. Retrobulbar neuritis is a type of optic neuritis, which is an inflammatory condition of optic nerve characterized by sudden onset of unilateral visual loss. Demyelination associated with multiple sclerosis is the most common cause. Here we present a 50-year-old man came with complaints of sudden onset diminution of vision with severe pain in right eye for 3 days. He had a history of diplopia and headache, which was not relieved by medication. He had a history of fever with cough and cold for 4 days, and is a known diabetic for 1 year on medication and newly diagnosed hypertension on medication. There were no history of associated vomiting, trauma, redness, or previous ocular surgery. No history of flashes and photos. On examination, extraocular movements in right eye was restricted. There was restriction in dextro elevation, depression, and dextroversion, and there was hypotropia, which increased with same side held it. There was proptosis with 23 mm. Vision was PL plus and PR accurate. Anterior segment was normal. There was grade 1 RAPD observed in right eye pupil, and fundus was normal. Left eye anterior segment and fundus was normal. On examination, 2nd, 4th, and 6th cranial nerve palsy was observed in right eye. So orbital apex syndrome was suspected. MRI brain with orbit was done, and since it was normal, we suspected retrobulbar neuritis. Routine blood investigation was sent. ESR and blood sugars were high. Since there was No improvement in symptoms. We did a repeat MRI orbit with contrast, MRA, and cavernous sinus screening, which showed mild increase in enhancement in right cavernous sinus, which suggested Tolosa syndrome. Patient was started on IV steroids for 5 days and followed by oral steroids on tapering dose. Patient was symptomatically better. Tolostan syndrome is presented with unilateral orbital pain with paralysis of third, fourth, and sixth cranial nerves, which are due to granulomatous inflammation of cavernous sinus and superior orbital fissure. It is associated with history of recent viral infection, and progression is very rapid. It has relapsing and remitting course. Oral steroid are the mainstay of treatment. Both symptoms and physical exam findings can be expected to resolve rapidly with oral steroid tapering regimen over 3 to 4 months. Antimetabolites like methotrexate, infliximab, mycophenolate has been used in steroid-resistant condition. Prognosis is excellent. We present a case of a 50-year-old man where patient's symptoms and radiological findings were initially misleading. Differential diagnosis has to be considered and carefully ruled out with proper investigation for every condition. So, Tolostan syndrome presents as a severe and unilateral headache with painful and restricted movements. Retrovalvular neuritis is a vision-threatening condition and it should be diagnosed at the earliest to prevent permanent visual loss. We enlight rare case of Tolostan syndrome mimicking retrovalvular neuritis here. Thank you.
Thank you, doctor. Just a minute. Why did you have this doubt of retrobulbar neuritis when extraocular movements were involved?
Because he had a painful loss of vision and vision drop was so high.
Typically in RBN, you don't expect the ocular movements to be involved or the other cranial nerves to be involved, right? So primarily it was, if the movement abnormality was not there, then okay, RBN was definitely would have been a doubt. But with the movement, this one present, probably we what was the first scan done? Was it a CT or a MRI?
MRI was done.
The first
Yeah,
MRI was normal, is it?
Yeah.
Then the second MRI with enhancement, it turned out to be positive.
Yes.
Okay, right. Thank you. Is it? It's me, huh? No, I don't. 1 minute. Just me, huh? It's here. Just me, Jose. Yeah. Yeah. Yes, start. Please.
Good morning. I'm Dr. Niyantri. I am a second year PG from Arvind Eye Hospital, Chennai. The title of my presentation is CP angle hits a 6. Cerebellopontine angle tumors account for 5 to 10% of all intracranial neoplasms. The most common tumors in the CP angle are vestibular schwannoma, meningiomas, and epidermoid tumors, and they most commonly present with hearing loss, tinnitus, ataxia, vertigo, and headache. Sometimes they do present with ophthalmic symptoms like nystagmus, decreased corneal reflex, and papilledema. Coming to my case, it was a 50-year-old male who presented with sudden onset binocular horizontal diplopia, which was worse in left gaze since 3 days. He was recently diagnosed with type 2 diabetes mellitus, but wasn't started on treatment yet. On examination, his vision and anterior segment and posterior segment examination was normal, but he had a abduction limitation in his left eye. So he was diagnosed with isolated left abducent nerve palsy and asked for baseline investigations, which revealed his RBS and HbA1c was high, and he was also asked to do a MRI, which revealed an enhancing left cerebellopontine angle mass extending into the left internal auditory canal, which was suggestive of a schwannoma. He was sent to a neurosurgeon for further management. The patient was lost to follow-up, but he did come again after 7 months, where now the patient presented with binocular horizontal diplopia, which was worse in his right gaze since 1 week. The patient had stopped experiencing his initial left gaze diplopia 6 months ago. In the meantime, he had undergone a detailed neurological evaluation, which had revealed a bilateral mixed hearing loss and pure tone audiometry, and he was treated with fractionated proton beam radiotherapy for 6 months. On examination, he had a abduction limitation, this time in his right eye. Again, baseline investigations were ordered, and this time his FBS and PPBS was normal. And MRI revealed that the size of the tumor remained the same, but he had brainstem edema from the radiotherapy, and he was diagnosed with isolated right abducent nerve palsy. Coming to the discussion, The cerebellopontine angle is a triangular space in the posterior cranial fossa, which is bounded superiorly by the tentorium, posteromedially by the pons, and posterolaterally by the petrous part of the temporal bone. And it contains the 8th nerve, 7th nerve, and the 6th nerve, and the anterior inferior cerebellar artery. CP angle tumors are most commonly present with 8th nerve palsy and 5th nerve palsy and 7th nerve palsy. The incidence of other cranial nerve palsy is actually less than 3%. The incidence of 6th nerve palsy in general population is 11.3 in 1 lakh population. Vasculopathy is the most common cause in adults older than 50 years, and it usually spontaneously resolves in 10 to 12 weeks. The treatment of vestibular schwannoma is usually surgical excision or radiotherapy. Sometimes radiotherapy can induce brain injury, which causes edema, temporary edema of the parenchyma, and raise ICT, which usually presents with headache, nausea, dizziness, and vertigo, but occasionally it does cause cranial nerve palsies. And the most commonly affected cranial nerves are the 5th and 7th cranial nerve. Coming to my conclusion, neuroimaging is necessary for younger patients and patients without comorbidities. The first left adjacent nerve palsy was most likely caused by diabetic vasculopathy because his RBS and HbA1c levels were high, and less likely from the tumor as it was growing more laterally. The next time when he presented with his right abducens nerve palsy, it was mostly due to the brainstem edema because this time his RBS and PPVS was normal, and lesser likely due to diabetic vasculopathy because his radiotherapy was concentrated on, but it could still also be diabetic vasculopathy because his radiotherapy was concentrated on his contralateral side. It was less likely because of the progression of the original tumor because the size had not changed. So sequential 6th nerve palsy is rare. Thank you.
Thank you, doctor. What were the findings in the patient initially? Was there corneal anesthesia? Was there 8th nerve involvement during the first presentation?
His CNS examination was normal.
Are you sure?
Yes.
It was in the internal auditory canal. How the 8th nerve could be normal?
He had, when he was sent for the detailed neurological examination, his audiometry was abnormal.
No, I'm asking the clinical test. Did you Rennie's test, Weber's test, all that you would have done, right?
Yes, all of that was normal.
Was normal?
Yes, all his other cranial nerves were normal.
So clinically, there's very less suspicion of CP angle tumor then.
Yes. He was only sent because he was 50 years old, and though his RBS and HbA1c was high, just to be sure we had sent for an MRI, but it had picked up a CP angle tumor.
Okay, thank you.
Morning everyone. I'm Dr. Udayashree from Karnal Medical College, Andhra Pradesh. Today I'm going to present craniofacial synostosis and herniation of brain tissue into orbital effects with severe proptosis. Coming to introduction, craniosynostosis describes partial or complete premature fusion of cranial sutures. Ocular hypertelorism, proptosis, beaking of the nose, and mid-face hypoplasia are the common facial features of the craniosynostosis. The prevalence of craniosynostosis is estimated to be 1 in 2,100 and to 2,500 live births. The sagittal suture is the most commonly affected, which is followed by coronal suture, which is followed by metopic, and then lambdoid suture. The syndromic craniosynostosis is a hereditary form of craniosynostosis, which is associated with extracranial phenotypes such as limb, cardiac, central nervous system, and tracheal manifestations. And also, syndromic craniosynostosis comprises about 15 to 30% of the total and specific single gene mutations or chromosomal abnormalities which could be identified in at least 20% of all the cases. Mutations of several genes including FGFR1, FGFR2, FGFR3 and TWIST1 and EFNB1 genes have been frequently reported to be associated with syndromic craniosynostosis. Coming to the case history, a 5-year-old child came to OPD with complaints of diminished vision and protrusion of right eye since birth, which is progressive in nature, now came with the complete protrusion of the eyeball. Child had similar history to the left eye, for which he has undergone enucleation. No significant family history is noted. On ocular examination, it showed severe proptosis with inflammation in right eye, which is associated with exposure keratopathy, and then left eye enucleation done. On examination, right eye is eyelids of flat severe proptosis and with conjunctival chemosis, and sclera is normal. On cornea, vascularized leukomatous corneal opacity secondary to exposure is noted. Other anterior segment details are not clear and posterior segment details are not visualized. In left eye, eyelids are flat, but in conjunctiva, there is no eyeball with anophthalmic socket with no implantation of the socket. And in general examination, patient is incoherent and not ready to accept commands. And in systemic examination, it is cardiovascular system, central nervous system, and gastrointestinal system are normal, but respiratory system, these is noted. And MRI of brain and orbits, we can see the complex craniofacial synostosis with endosteal scalloping and herniation of brain tissue into the right orbit with apical narrowing. And this is the case. Coming to the discussion, the craniosynostosis or autosomal dominant birth defects caused by premature fusion of one or more several cranial sutures in utero, resulting in restricted skull growth and brain development, as well as a variety of other phenotypic dysmorphisms. The ocular consequences of craniosynostosis include malformed shallow orbits leading to exophthalmos or proptosis. These malformations can lead to vision-threatening sequelae from possible amblyopia, strabismus, exposure keratopathy, and potential optic nerve injury. Differential diagnoses include Apert syndrome, Mankey syndrome, Pfeiffer syndrome, Crozen syndrome, and also some non-syndromic craniosynostosis. Surgical management is the treatment modality of choice to curb the maldevelopment of the midface and orbits to prevent blindness and intellectual disability related to the restriction of the brain and orbital development. Complications are raised intracranial pressure, mental subnormality, problems with vision, exposure keratitis, and aspiration pneumonia, breathing problems, and stridor. In conclusion, the management of craniosynostosis is complex and difficult and requires a team of subspecialties including pediatricians, oromaxillofacial surgeons, plastic surgeons, neurosurgeons, otolaryngology, and ophthalmologists, pediatric and oculoplastics. The nurses involved need to be specially trained to assist in recognizing complications and educating the families. An interprofessional team approach will provide the best patient outcomes. There is some ongoing work investigation the role of tyrosine kinase inhibitor in mutated FGFR related craniosynostosis conditions. Unfortunately, these studies have not been tested in humans and are likely years away from clinical use. Thank you.
Thank you, doctor. What was done for this patient?
So, the enucleation done for both eyes, sir.
Okay. So it would have been nicer if you could have shown us the pictures of the neuroimaging pictures as well. But
actually, we have referred to higher centers. I didn't have
but
the.
Okay, fine. So it was a report that you saw.
Yeah.
About herniation of the tissue into the orbit and all that.
Yes,
okay,
sir.
Fine. Thank you.
Thank you, sir.
So from the second author, like Dr. Saumi Roy.
Hi, so good morning. We'll be talking about an old female who came to us with recurrent chalazion INC done outside and how we managed it. So sebaceous cell carcinoma for India, it's the most common tumor, most commonly seen in the upper lid, most commonly involving the lateral canthus. And whenever you see an elderly patient with recurrent chalazion 2 or 3 times operated, the first thing you think of is sebaceous cell carcinoma. And that's why you always biopsy a chalazion. So let's see what happens. So a 75-year-old female with a recurrent swelling as seen on the right outer aspect of the upper lid since 8 months, undergone 2 episodes of incision curettage. She has history of bleeding from the lesion, painless progressive increase, loss of lashes, and she had no other signs of involvement of the orbit, extraocular muscles, or systemic involvement, lymph node involvement. Her general physical examination was normal. Lymph node examination showed no enlargement in any of the groups in the neck. Now the ophthalmic examination, as you can see, there's a 10 mm in the horizontal and 7 mm in the vertical dimension mass on the right upper lid extending into the posterior lamella, that is the conjunctival side. There are dilated vessels seen on the lesion. It's a yellowish firm lesion with areas of necrosis, hemorrhage, and it is involving the lateral canthus, as can be seen from the lateral view. And on eversion, there was the mass infiltrating up to 8 mm from the gray line on the conjunctival side. The visual acuity, it was logma 0. The movements were normal. There was a pterygium, and a non-significant finding for this patient. The posterior segment was normal. So we made a provisional diagnosis of a right upper lid sebaceous cell carcinoma involving the lateral canthus. We planned for an excision biopsy with a map dot biopsy. Mets workup was negative. We did a wide margin excision biopsy with a 12-point map dot biopsy. And the microscopy, it showed, as you can see, nuclear atypia with peripheral palisading of cells as seen in image A. And in the image B, you can see the red arrow is pointing the mucocutaneous junction, and the black shows the cell nests just in the subconjunctival space, involving the tarsus and the meibomian glands. The image D, it shows a characteristic separation artifact. So all of these findings, they were suggestive of a basal cell carcinoma involving the tarsus and the posterior lamella of infiltrating variety. So the AJCC classification came to T2C N0 M0. The tumor was surgically resectable. So we went for a full thickness resection, and it left a 16 by 10 mm defect involving the lateral canthus. So we reconstructed the posterior. So here we can see the defect. We raised a tensile flap. In the second image, the green arrow shows the periosteal flap to reconstruct the posterior lamella. We rotated the tensile flap to reconstruct the anterior lamella, and the lateral canthus was reconstructed by fashioning a tarsal strip out of the lower lid and anchoring it to the periosteal flap. So this is our 18 months follow-up. The lateral canthal angle is maintained. There is mild ptosis, but the patient is happy with the cosmesis. There is no recurrence. So basal cell carcinoma, though it's the most common eyelid malignancy in the world, in India it's the second most common, and squamous cell and melanoma still have to catch up. And the classical features of basal cell carcinoma, usually on the lower lid, it's a infiltrating rodent ulcer, indolent for years together. Whereas this patient, she had a 9-month history with a globular mass on the upper lid with a yellowish lesion. So this was a masquerade basal cell carcinoma as a sebaceous cell carcinoma. Now the poor prognosis, she had one of them that was involving the tarsal plate and conjunctiva, but after complete resection for 18 months, she has had no recurrence. So always biopsy a sebaceous cell carcinoma or a lesion, a mimicking sebaceous cell carcinoma. Thank you.
Thank you, Dr. Shalan. It was a very good case. As you pointed out, biopsy actually is very important, right?
Yes.
Good. Thank you. Is Dr. Abhishek here once again?
Good morning, everyone. Today I am going to present on step-by-step evaluation of ocular surface squamous neoplasia in a tertiary care center.
Can you put the mic close to your mouth, please? Just bend it close to your mouth. Yeah.
OSSN refers to entire spectrum of dysplastic pre-invasive malignant squamous lesion of the conjunctiva and the cornea. According to Lee and Hurst grading of OSSN, it is of 3 types: benign dysplasia, pre-invasive OSSN, and invasive OSSN. In benign dysplasia, it consists of papilloma, pseudoepitheliomatous hyperplasia, benign hereditary intraepithelial dyskeratosis. In pre-invasive OSSN, conjunctival or corneal carcinoma in situ, conjunctival intraepithelial neoplasia. In invasive OSSN, it consists of squamous cell carcinoma, Kaposi's sarcoma, lymphoma, and mucoepidermoid carcinoma. Mucoepidermoid carcinoma is the most aggressive OSSN. Now there are 3 types of CIN, mild, moderate, and severe. Mild is dysplasia, involves the lower third of the epithelium. Moderate is dysplasia extending into the middle third, and severe dysplasia involves the full thickness of the epithelium. My objective is to present the step-by-step diagnosis and management of OSSN cases at our institute. Materials and methods that are used. Place of study was eye department, Vimsar Bulla. Period of study was May 2022 to October 2022, and sample size was 12. Study tools and techniques that were used: visual acuity, NCT, slit lamp biomicroscopy, funduscopy, fundus photography, base scan, MRI brain and orbit, complete blood count, peripheral blood smear, and impression cytology. Methodology that was used, a total of 12 patients with growth in conjunctiva and cornea were taken, and following procedures were done. Impression cytology, second one is excision and biopsy, and third one is follow-up after 7 days. In conjunctival impression cytology, sterile glass slide was taken and pressed over the growth. The impression of the growth was taken and stained with the hematoxylin and eosin stain. Procedures that were done, rose bengal stain was done over the growth, 5 millimeter clear margin from growth marked with cautery, then growth was excised, double thaw cryotherapy done over the conjunctiva, then alcohol given with swab stick, then amniotic membrane graft sutured using 80Y creel, and growth was sent for HPE. My result was, out of 12 cases, 2 cases came with recurrence. 1 case showed brain metastasis. Leukoplakic cases were 3. Papilliform cases were 3. And gelatinous cases were 6. Both cases of recurrence were high-grade invasive squamous cell cancer. These are different types of OSSN. Now the histopathological reports of OSSN, which shows the low-grade OSSN, microinvasive squamous cell cancer G1 well differentiated form. Third one is invasive squamous cell cancer G1 well differentiated, and fourth one is invasive squamous cell cancer G2 moderately differentiated. So my take-home message is not to miss the lesions. It may mimic pterygium, it may have feeder vessels, it may be elevated, awkward, progressive, extensive, and fixed to tissues. If OSSN in younger patients were detected, HIV need to be ruled out. Thank you.
Thank you very much, doctor. Thank you very much. Next, we will have Dr. Siddharth Madan. Are you here? Dr. Siddharth Madan?
Very good morning to one and all. Today I'll be presenting a rare case of spontaneous evisceration of eye in dengue fever. As we all know, dengue is a flavivirus and transmitted by Aedes, female Aedes mosquito. The most common symptom of dengue fever, that is the visual symptom, is a blurring of vision followed by the central scotoma. So in all dengue fever patient, especially when the platelet count is low, we should do a thorough evaluation for any serious ocular complication. This case of dengue fever presented a spontaneous evisceration to us. Coming to the case detail, a 25-year-old young male presented to us with loss of vision, swelling and bleeding from the left eye since last 4 days. There was a history of high-grade fever with chill and rigor and a severe headache for the last 10 days. He was tested NS1 antigen positive for this and having a low platelet count. On the day 6 of the fever, he suddenly experienced pain in the left eye, which was gradually increasing in the intensity, followed by there was a central positive scotoma and swelling of the left eye. There was no history of an ocular trauma or any previous ocular pathology. The treating physician advised non-contrast CT scan of the orbit, which revealed a proptosis with the preseptal hemorrhage of the left eye. After 10 to 12 hours of the pain episode, he suddenly had a press bleeding from the left eye and the pain was relieved. The patient presented to our OPD on the 4th day of the bleeding episode, and a thorough clinical evaluation revealed all the posterior and anterior segment and visual acuity of right eye was within normal limit. But in the left eye, the visual acuity was no perception of light. Eyelids were edematous, the eyelashes were matted with bloody discharge, the conjunctiva was congested, and on examination of the cornea, there was a central 8 to 9 millimeter perforation with surrounding 2 millimeter corneal tissue which was visible and having the infiltration and necrosis, and there was prolapse of the uveal tissue or the intraocular content. These photos showing the central corneal perforation with the surrounding corneal tissue having infiltration. This shows the decreasing trend of the platelet count of the patient starting from 46,000 to 32,000 and the 22,000. This film shows the proptosis of the left eye along with the preseptal hemorrhage the patient was carrying with him at the time of presentation to our OPD. We manage the case after proper stabilization of the general condition of the patient and after attaining a normal hematological profile. We did evisceration of the left eye, and after 4 weeks, a prosthetic eye was fitted. These are the intro of images showing eviscerated eye with conformer in situ. This is the post of MRI scan showing the a thick sclera in the eviscerated eye. This is the post of 5-week picture showing a reasonable cosmosis. Coming to the discussion, there are 4 types of dengue viruses detected in Indian subcontinent, and recovery from infection by one serotype gives lifelong immunity against a particular serotype. But later on, if the patient is affected with the other serotype, then it may lead to dengue hemorrhagic fever and dengue shock syndrome. Coming to the pathophysiology, as you all know that in dengue fever there occurs thrombocytopenia, capillary fragility, and platelet dysfunction that leads to the various type of intraocular and retrovalvular hemorrhage. So in initial stage, if there is macular hemorrhage that lead to central scotoma, there is retrovalvular and intraocular hemorrhage which increases the intraorbital and intraocular pressure. So there may be globe rupture, the globe cannot withstand this pressure and there occurs spontaneous evisceration. So if the initial stage, like when the patient presented with proptosis and pain, if the pressure bandaging and lowering IOP can help. To conclude, monitoring a platelet count and its correlating visual symptom may prevent this disaster complication. Awareness among the general physicians treating dengue about the possible ophthalmic complication in this patient is essential. Thanks a lot for the patient hearing.
Thank you. But it was really surprising that patient, after this bloody discharge, 4 days later he comes to the ophthalmologist.
Yeah.
Yes. Was there any platelet concentrates given to the patient? Was there any history of blood transfusion, platelet concentrates being given to the patient?
Yes, sir. Actually, the platelet are infused by the general physician when.
Actually, there is one more paper. The author didn't come. Actually, the thing is, it's well known that after platelet concentrates, sometimes patients develop panophthalmitis or endophthalmitis as well. So, because in the pathophysiology which you put, there is no infection involved, right?
Yeah.
But why the patient had infiltrates in the cornea,
Sir,
and probably because of exposure.
Yes, sir. I think it's after 4 days he presented to us. So
Yeah.
by the meantime,
It
there
could
is
have
some
got
superinfection.
infected. So it could be that, or it could also be that the patient had a panophthalmitis
Yeah.
secondary to the platelet concentrates, or
Yes.
infected. The blood could have been contaminated
Yes.
and all. So actually, we may think it is very rare, but it is quite possible. The
Yes.
platelet concentrates are stored at a little higher temperature, so
Yes.
the contamination is possible. Okay, right then. Thank you. Good.
Thank you so much, sir. Thank you so much.
Morning all. Today I am going to present an interesting case of orbital COVID-related mucormycosis with orbital apex syndrome. Mucormycosis is a debilitating invasive fungal disease which is commonly called as black mucus. This disease is a predilection for severely immunocompromised patients. Rhinoorbital mucormycosis, whereas it's an entity wherein nasopharynx is affected first, which then rapidly spread to orbit and then to brain if not treated aggressively. This case is being presented to enlighten the need for prompt intervention as to prevent the life-threatening complications. My case is a 49 years old male who is a known case of uncontrolled diabetes with a positive history of COVID-19, presented with a sudden onset of protrusion of left eye and with a loss of vision. On evaluation, patient had total ophthalmoplegia with no perception of light in the left eye and with complete ptosis with axial proptosis of 25 mm and pupil was 4 mm not reacting to light. Since the patient has nasal symptoms, ENT opinion was obtained and imaging by biopsy were done. This is the MRI image which showed T1, T2 hyperintense mucosal thickening seen in left maxillary sinus, which suggestive of fungal sinusitis with left orbital cellulitis with proptosis and with optic neuritis. An histopathological examination also revealed invasive fungal infection with consistent with mucormycosis. And based on the clinical features and the above imagings and histopathological examination, patient was diagnosed as left-sided rhinoorbital mucormycosis. To prevent further complications to spread to the brain, with a collaboration with the ENT department, the combined functional endoscopic sinus surgery with total lid sparing orbital excitation was done for the patient. This is a picture of post-op patient. Rhinoorbital mucormycosis is a rare fungal infection with high morbidity and mortality despite appropriate and adequate treatment. Almost it always occurs in immunocompromised individuals. Though mucormycosis exhibit variety of clinical symptoms, rhinoorbital involvement is the most common clinical presentation. Being a rapidly progressive disease, even slight delay in the diagnosis or appropriate management can cause devastating implication on the patient's survival. To conclude, ocular manifestation or initial presenting symptoms in case of rhinoorbital cerebral mucormycosis. This devastating and debilitating COVID-related mucormycosis has many atypical unique features which cost the life and vision of the patient with various ocular manifestation if not intervened at the earliest. These are my references. Thank you all.
Thank you, doctor. So, what was it? I mean, what was the time difference between when the patient was COVID positive and when he developed this?
Actually, 2 weeks before.
2 weeks before. So, what was the treatment? What was the treatment that he had received when he had COVID? Was he on high dose steroids?
Yes, sir. High dose steroids given. Specifically, the patient was not on any COVID vaccination. Not
Okay.
any vaccination. Severely uncontrolled diabetes, sir.
Okay. So, how long was the patient followed up after the surgery?
After the surgery, he was advised to actually monthly follow-up was done, sir, and patient
Okay.
was advised for a prosthetic eye, but he was not willing at that present time, sir. So
Okay.
lost to follow.
Okay. Thank you.
Thanks.
Arvind Eye Hospital, Coimbatore. The hook atrocities, the curb curses. Yes, the hook nearby us can be as nasty as this cartoon character, Captain Hook. No conflicts of interest, no financial disclosure. Can you tell the similarity between the pictures? Yes, they are all lid lacerations involving the caniculi and mostly the young patients. Canalicular laceration is commonly considered as ocular emergency caused by trauma to eyelids and periorbital area in about 16% of all eyelid lacerations. We report a case series of 21 patients with lid lacerations with or without involving the canaliculi due to injury with various kinds of hooks commonly used in daily lives. And to evaluate the surgical outcomes of these canalicular laceration repairs with self-retaining monocanalicular intubation system. This was a retrospective study. The data collected from the hospital records included patient's demographic detail, mode of trauma, associated ocular injuries, time interval between the injury and surgical intervention, post-operative complications, and the follow-up period. The patients underwent lid tear repair with the placement of monocanalicular stents between the period of March 2019 and July 2022. Repairs were done within 24 to 48 hours of injury. In the method, the distal end of the self-retaining monocanalicular stent was cut to the beveled edge. It was inserted from the cut end of the caniculi, pulled from the opposite end, and passed through the opening and secured and sutured with the lid. The wound was assessed on post-operative day 1, then followed up to 2 weeks, 2 months, and 6 months. The stent was removed at around 2 months in few cases, while few had extrusion of stent. Patency was checked by syringing. The mean age of patients were 2 to 65 years, 80% were male. In 54% cases, left eye was involved. The type of hooks that we got was most commonly two-wheeler handlebar hook, then cradle hook, four-wheeler seatbelt hook, blouse hook, and cement bag metal hook. These are the common cradle hook found in the home. In 53% of cases, upper canaliculi was involved. These are some pre-operative pictures of the victims. The most common ocular injuries we found were tarsal plate fracture, conjunctival tear, LPS tear, and extraocular muscle injury. In the figure here, this black arrow shows the superior oblique avulsion. In the surgery complications, we found stent extrusion and loss, punctal eversion, wound site granuloma. The most common was stent extrusion and loss. These are some of the pre-op and post-operative pictures of the patients with the stent in situ at 2 weeks. Now, the canicular lacerations, as I've told, most common injury of the lacrimal drainage system because of their exposed position. Naik et al. In their study found fastening hook of sari as the most common cause, while we found that two-wheeler handlebar hook as the most common cause in our study. Now, some food for thought. We can prevent these injuries by preventing the child from sitting in front of two-wheeler having hooks. We can wrap the hooks if the child is sitting or standing in front of hook, like we baby-proof the surroundings of the home. We can baby-proof the hooks also. We have to be vigilant when the child is near the cradle or playing around the hooks, and be careful while working near metal hooks and all these conditions and all little awareness can prevent the child and other patients to get injured from the hooks. These are my references. Thank you all.
Thank you for the very informative talk. I mean, how many patients at the end had patent?
Patent canaliculus.
Yes.
So 19 patients from 21 had patent canaliculus.
Okay.
2 had non-patent.
Okay. Did you present that data, that results in the results? The syringing findings, because in the methods you've told that you check the patency with syringing,
yes,
but
yes.
you have not presented the results about it, right?
No, sir.
Yeah,
I
you could
forgot
have
to mention.
mentioned it.
Yes.
But otherwise, it was a very nice paper. Thank you.
Thank you so much.
Yeah. Next, we'll have.
Good morning to one and all. I'm presenting before you Little Things May Matter Most, and it's a case of infraorbital foreign body leading into orbital cellulitis. It was a 57-year-old male with no known comorbidities presented to our OPD with a swelling and pain in the inframedial aspect of the left orbit for 5 days duration and pus draining from it for 2 days. No complaints of defective vision, eye pain, restriction of eye movement, but he gives a recent history of injury which occurred 1 week back while cutting wood. General examination was within normal limit. Ophthalmic examination showed a right eye with a normal limit and with a best corrected visual acuity of 6.6. Left eye showed vision of 6.9 improving to 6.6 partial. And the anterior segment examination revealed a small defined fluctuant swelling 2 into 2 centimeter in the inframedial aspect of the orbit with a small opening of size 3 millimeter over it and pus draining from it. Conjunctiva, pupil, lens pressure was normal with complete non-restricted eye movements. The patient was admitted. We started them on routine IV antibiotics, routine blood and culture. But by day 2, the vision dropped to 6.18 with no pinhole improvement. Patient developed pain and diffuse tense or periorbital swelling and pus draining from the wound. There was severe conjunctival congestion and chemosis with sluggish pupil reaction and painful and severely restricted extraocular movements. We did an MRI which showed edematous infiltration of the orbital connective tissue suggestive of orbital cellulitis and infraorbital signal changes, query suggestive of foreign body. We did an extensive wound exploration and 3 wooden pieces were taken out. We treated with potent IV antibiotics like linezolid and metronidazole and other supportive management. The patient condition improved well in due course with a best corrected visual acuity of 6.6 partial. To the discussion, retain wooden foreign body in orbital, periorbital region is very dangerous as it is a good culture medium due to its organic nature and can be missed even by a CT or MRI imaging. Even a small retained particle can cause severe ocular intracranial infection which can either be bacterial or fungal and brain abscess. The take home is, even an innocent looking small abscess may turn into a villain. High suspicion and imaging should be done in case of any entry wounds. Aggressive wound exploration and IV antibiotics is of utmost importance. Thank you.
Thank you, doctor. It was an informative one. How deep were the foreign bodies into the orbit like?
Actually, our consultant did it. It was very deep. It was in the wound was 4 millimeter below the orbital margin.
Okay.
But it was intraorbital.
Okay, fine. Okay, thank you very much. Thanks.
Thank you.
Now we'll have Dr. Pradyumna Mishra talking to us on.
Hello. Good morning, everyone. Today I'll be speaking on modified studies, our approach of lower eyelid reconstruction at a tertiary healthcare center. Surgically, eyelids can be divided into the anterior lamella comprising of the skin and the orbicularis oculi, and posterior lamella which comprises of the conjunctiva, tarsus and the eyelid retractors. Both lamella usually require reconstruction and full thickness defect. So Mustardi's rotation flap is often employed for wider and deeper lower eyelid defects which involves more than 2/3 of the eyelids. Mustardi in 1971 used this procedure to construct both the anterior and the posterior lamella, and the frequent complications were downward contraction and sagging of the flap and ectropion of the lid margin, whereas Callahan in 1980 modified it to prevent these complications by saying that the zygomatico cheek flap must be carefully designed, rotated and sutured as high as possible so that the palpebral fissure is only a narrow slit postoperatively. So basic principles which are needed to know for flap and graft A graft can be laid on a flap can be laid on a flap, but a graft cannot be laid on another graft because of lack of blood supply. So this is the Masadi's technique. In this, first we have to mark the tumor along with 3 to 4 millimeter clear margins on either side, on either and on both the medial and the lateral aspect. Then from the medial aspect of the extended line, we move downwards towards the cheek with and the height of the this line is should be 2/3 of the base of the triangle, and then we join the lateral angle of the tumor mark, and we join it to the tip of this triangle. Then from this we from the lateral canthus we mark the incision line superiorly and temporally, and then we curve it downwards towards the earlobe. Then the flap is raised in the submucosal plane, and the flap is rotated and sutured alternately using 4-0 silk and 6-0 vicryl. Purpose: to study the outcomes of Mastardi's cheek rotation flap in lower lid reconstruction to achieve near normal eyelid. Total of 18 patients underwent modified Mastardi's cheek rotation flap, including diagnosis, post-op complication, and surgical outcomes. Mastardi's flap was done in case with basal cell carcinoma, squamous cell carcinoma, sebaceous cell carcinoma, melanin, all of which involve the lower eyelid. So this is the case 1. In which the patient presented with a nodular ulcerative lesion which was excised, and the lid defect was repaired using the Mastardi's cheek rotation flap. This is post-op second week image. The biopsy came out to be basal cell carcinoma. This is a case of meibomian gland carcinoma involving the lower lid, and this is the post-op image of the same 2 weeks later. So this is another case of meibomian gland involvement, in which the patient underwent cutler beard for the upper lid meibomian gland involvement, followed by the patient came with the lower lid meibomian gland carcinoma, and patient underwent this Mastardi's cheek rotation flap. Result: there was good eyelid coverage and eyelid support. There was no skin necrosis or atropion observed. In 2 cases, a lower position of the free edge of the new eyelid was noticed after the edema subside without any important functional impairment. All the patient had an acceptable degree of rigidity and immobility of the new eyelid. The scar which remained was atrophy, had fat atrophy. However, the eyelid closure was not affected since the upper eyelid were functional and slightly ptotic. The modified Mastardi's, it ensures good coverage and satisfactory functional and aesthetic result in case of large full thickness defect of the lower eyelid. And modified Mastardi's, even after more than 40 years of history, remains the most versatile method. Thank you.
Thank you very much. It was a very nice presentation. Thanks. So next we will have Dr. Mihir Mishra talking to us on the
Good morning, everybody. So my study is on outcome of wrapped and unwrapped PMMA implant in an ophthalmic socket. Enucleation and evisceration are the most commonly performed destructive surgeries, and an orbital implant function is to replace the lost orbital volume, maintain the structure of the orbit, and impart motility to the overlying ocular prosthesis. The PMMA is the most commonly used non-integrated, non-porous solid implant, and no other Indian study which has reviewed the outcome of PMMA implant following evisceration and enucleation in the single study. So aim was to study the clinical outcomes of PMMA implant in patients following evisceration and enucleation at a tertiary eye care center in central India. Primary objective was to evaluate the implant retention and implant migration, and the secondary objective was to see the implant movement and the implant related complication like implant exposure, extrusion, conjunctival dehiscence, and the sulcus deformity. So study area was Oculoplastic Services, MGMI Institute, Raipur, Chhattisgarh. All patients with age groups attended the outpatient department, and indication according to the enucleation evisceration will include prospective interventional case series with 9 months period. The inclusion criteria had all the indications for the evisceration enucleation, and exclusion criteria were mostly patients with contracted socket and patients with irradiation or any other congenital anophthalmia. So methodology included the demographic details and the detailed history, comprehensive anterior and posterior segment examination, and oculoplastic examinations, relevant post-operative and pre-operative radiological investigations were done. Surgical techniques and type of surgery, rehabilitation, and follow-ups were done. So methodology was B-scan ultrasound was taken for the axial length of the normal eye. Donor sclered wrapped scleral thickness was taken as approximately 1.5 millimeter for this donor sclera. Implant diameter was done by axial length minus 5.5 millimeter, including the prosthesis. And the finalization of the size of the orbital implant to be used was based on the clinical and intraoperative findings of the surgeon and the patient's orbital and ocular anatomy. The patient's follow-up was in first, fourth, and 6th weeks post-operatively, and 6th post-operatively, we gave this custom process along with complication which were there noted in that. So this is the surgical procedure which was done for the evisceration with the implant inside the skull pocket, and this is for the enucleation. We have a scleral wrap implant which is placed inside, and it is attached to the four metal muscles to the four quadrants, and the conjunctiva is closed. And this is the post-op photographs where we see the implant is in the central position and there is good motility along with the cosmesis which is seen after the CMP. So mean age was around 41 years and duration was around 119 weeks. The mean axial length was around 22. The size of the implant was around 16 millimeter, and the horizontal and vertical excision was about 7 and 8 millimeter. Mean motility index was around 4 millimeter. So diagnosis most common was the perforated corneal ulcer, then comes the phthisis bulbi and staphyloma. So coming to the presentations, we had more of acquired conditions, and major complications were maximum 2-3 patients, and minor complication was in just 3 patients. Orbital volume replacement was there in case of 78%, and orbital implant retained was in case of 98%. So these are the good results we got as compared to the other studies. So concluding, PMMA orbital implant in anatomic socket provides adequate volume replacement and good anatomical and functional outcome in case relation to the implant prosthesis movement with minimal complications. Thank you.
Thank you, sir. It was very informative and a nice presentation. I'd like to know how do you manage patients where this implant extrusion occurs, sir?
Yes. So whenever there is extrusion, we have to see like how much it is there, the dehiscence part of the conjunctiva or the sclera in case of evisceration. And in those cases, we try to put an extra sclera, donor sclera in that, if at all it is not necrosed. So any necrosis of the sclera, we have to excise it, then put the flap again, and then we can cover it again. Or if at all we feel that the implant is oversized, sometimes we put 20, 22, so then we have to do the implant exchange, and then we can put a smaller implant. Thank you.
Thank you very much. Thank you.